I'd also like to thank our partners who help us get the word out about the forum. They're Interact for Health, KET, Health Enterprises Network of Louisville, and the Kentuckiana Health Collaborative, if you'll join me in recognizing them. So as I noted, this is the 16th annual Bost Forum brought to you by the Foundation for a Healthy Kentucky. The Foundation is a nonprofit, nonpartisan organization that has a single goal, and that goal is to improve the health of Kentuckians. We do that through policy advocacy, grant making, research training, and partnerships. Most recently, the Foundation has taken a leadership role in advocating for policies known to reduce smoking and other tobacco use. We formed a partnership with the Bevin administration for the singular purpose of ensuring that Kentucky's Medicaid population retains their health coverage when the 1115 waiver Kentucky Health rolls out. We know that health coverage leads to better health, and we're committed to the long-term reduction in Kentucky's uninsured rate. The Foundation has also has demonstration projects in 7 Kentucky communities focused on reducing childhood obesity and addressing the kinds of toxic trauma in childhood that can lead to many problems, including chronic disease later in life. As you may have heard, we are involved in the Focus on the Flu campaign, our partnership with the Kentucky Medical Association to ensure Kentucky doesn't have another flu season like we did last year. Have you gotten your flu shot yet? If not, this week's a good week to do it. Helping the Foundation determine its priorities and oversee its work are my colleagues on the Board of Directors. I'd like to take a moment and acknowledge them now. So if you're a board member of the Foundation, I'd ask that you stand and be recognized. It has, I'm ad-libbing here a bit, but that has been one of the privileges of my life to serve on the Foundation board in 2 terms. There's just a group of outstanding people that are drawn to the mission of the Foundation. And, if you ever have the opportunity to do it, I guarantee you it'll enrich your life. So, again, my personal appreciation of my fellow board members, both current and past. I'd also like to thank the committee of experts, executives, and professionals who helped us put together today's forum. Their names are listed on the screen. And so those committee members, if you would you stand and be recognized? I think most of them are standing in the back because they're working. And then one more group that I think deserves recognition, and many times when you're paid staff, you don't necessarily get that because it's your job. But we have a great Foundation staff that I've also been privileged to work with, and I'd like for them to stand and take a bow, or if they're in the back of the room, raise your hand and be recognized. Okay, the theme the Planning Committee chose for this year's forum is Kentucky's Substance Use Epidemic, a Solutions Update. Over the past decade, the number of Kentuckians who die from drug overdoses have steadily climbed to more than 1,500 each year. Today, we're going to explore the addictions that lead to these overdoses, focusing first on where we stand as a state on the national stage, and then delving into a more detailed examination of the underlying causes and how we might begin to heal our residents. Thank you all for being here and for your willingness to and interest in joining us in this goal. And with that, I'll turn it over to our CEO, Ben Chandler. Thank you all.
Thank you, Mark, and good morning to everybody. Nice to see such a big crowd fill the room. We are very excited to put on this forum today, and we are greatly appreciative, and I'll echo Mark on this, to our sponsors who, again, allow us to put this on and allow everybody here to come without having to pay. And I don't know about you all, but I like that. So please give another round of applause to our sponsors. Our goal is to share the solutions that are working all over the state. We know that there are solutions to some of our health care problems and health problems, and we want to make sure that everybody knows what those solutions are and that they're put into practice. And that's one of the central reasons why we have this forum. And in this particular case, we're going to be exploring the topic, as Mark said, of substance use, which obviously is an important topic here in the Commonwealth of Kentucky today. But before we get into that, I'd like to recognize and thank the members of the Foundation's Community Advisory Council and ask them to please stand at this time. These individuals are invaluable to the Foundation's work to improve the health of Kentucky. And as we move forward, they're going to be the focal point of our expanded community engagement strategy. Their work will be to raise the awareness of community health needs and to help launch, or where they already exist, to turbocharge the multi-sector collaborations that are needed to address those needs. The people who you saw stand represent the Foundation's liaisons in communities all over the state. We started with 31 folks. We're now at the moment at 23 because we're in a period of transition, but we intend to substantially grow that number under the leadership of our Community Advisory Council Chair, Robert Slayton, and Vice Chair, LaChrista Finn. So Robert, LaChrista, and all the rest of you, thank you for the work that you're doing and for even greater work ahead. One of the things that several of the council members do is review nominations for the Foundation's Healthy Kentucky Policy Champion Award. This is the first year that we've given this award away. It is the brainchild of our former chair, Charlie Ross. We appreciate the idea, Charlie, because what we know is we've got people doing good health policy work in their communities all over this state. And what we want to do as a foundation is we want to put a spotlight on those folks who are advocating the policy changes that will make Kentucky healthier. This year we presented 8 awards, and I'd like to have them stand up as I name them and then remain standing. And audience, please hold your applause until they're all named. Here they are. Jack Rose, Mayor of Murray, Kentucky, honored for his leadership in passing a comprehensive smoke-free law in Murray. McCreary County, Kentucky, identified as a bright spot in Kentucky for achieving outsized health outcomes given the challenges that this community faces. Dr. Van Breeding of Whitesburg for his leadership in combating substance abuse in southeastern Kentucky. Dr. Pat Withrow, a Paducah cardiologist, for a myriad of policy advocacy efforts, including his work to support an increase in Kentucky's cigarette tax to reduce smoking. Wayne County, also identified as an Appalachian Kentucky bright spot for better than expected health outcomes. Brandy Harless, Mayor of Paducah, for leading the campaign to strengthen the smoke-free law in her city. The Casey County Youth Coalition of Liberty, Kentucky, for changing the culture of their school campus to reduce student smoking by as much as 10%. And finally, Mayor Jim Gray and Lexington Legends President Andy Shea for working together to make all ball fields in Lexington tobacco-free. These are your 2018 Healthy Kentucky Policy Champions. Please give them a round of applause now. And I'll ask them I'll ask them to make their way to the stage for a photograph with our board and council leadership. Please, folks, come on up. Now, as they're here, I guess we've got everybody who made it today anyway. I have the great honor of announcing the Healthy Kentucky Policy Champion of the Year. And this is not an easy task, and thankfully I don't have to make this choice. We've got a little committee that makes the choice of the winner, of the nominees, the ones who get the awards. We have to pick a winner, and that winner receives a $5,000 award to give to the nonprofit of their choice working to improve health in Kentucky. And in our first year, guess what? We have a tie. So they're going to have to split the award, and the winners are Wayne and McCreary County. Wayne and McCreary counties were recognized as bright spots in Appalachia in a recent study released by the Foundation for a Healthy Kentucky, along with the Robert Wood Johnson Foundation and the Appalachian Regional Commission. Bright spots are communities that defy predictions for health outcomes given the challenges they face. What's happening in Wayne and McCreary counties is changing our understanding of what's possible in these and other Appalachian counties. They show us that there's always somewhere to start when working to improve health. Many, many people contributed to the healthier than expected outcomes in these counties. Accepting the awards on their behalf are a number of people, including who have all been very instrumental in these efforts. In particular, I will mention the county judges of those counties, the Honorable Douglas Stevens, McCreary County Judge Executive, and the Honorable Michael Anderson, Wayne County Judge Executive. Please give them one more round of applause. Thank you all so much for all the work that you've put forth throughout this process and the ongoing efforts to help our citizens be healthier. Thank you all. And now I would like to introduce the moderator of our first panel this morning. This panel will help us understand the current state of addiction in Kentucky in terms of both the human and the economic toll. Our moderator is Dr. Wilson Compton, Deputy Director of the National Institute on Drug Abuse, or NIDA. NIDA supports most of the world's research on the health aspects of drug abuse and addiction. Dr. Compton has authored more than 150 articles and book chapters, including many drawing attention to the prescription drug abuse problem in the United States. He is the recipient of multiple awards, including the prestigious Health and Human Services Secretary's Award for Distinguished Service. We're grateful that he has traveled from headquarters in Maryland to join us today. We appreciate it very much, Dr. Compton. Welcome, and come on up.
Well, it's a pleasure to be here this morning, and I really appreciated the chance to hear about the remarkable work going on in the local areas across Kentucky. And this is a theme. that I want to emphasize just for a minute or two is the importance of local efforts to address drug abuse and drug addiction issues. When we think about what causes drug abuse and drug addiction, we can conceive of it as sort of a clear example of environment and individual risk factors. Some think about this as, oh, it's all in terms of nature, it's all in terms of the genetic background, and it runs in families. That's true. No, it's all about the environment. It depends on who you grow up with and what kind of problems you had as an early child. That's true. Turns out it's the combination of those that makes the biggest difference. And so how do we intervene to change the environment? I can't change your genetic background, but we certainly can change the environment that you live in. And that's what these local efforts are all about. Because it's only at the local level that we will really do something to address this scourge that's impacted the whole country. Now, my job is to serve as moderator, so I only have a couple of minutes of material, but I want to present to you a little bit about the national picture in terms of the opioid crisis in our country, and emphasize for you just for a moment how NIH, the National Institutes of Health, is gearing up to address this using the entire set of resources all across NIH. So, of course, the National Institute on Drug Abuse has been engaged in this issue for decades, but this is a new issue for all of the National Institutes of Health. So we have our infectious disease colleagues to address hepatitis C and HIV. We have our aging colleagues to look at the issues involved in an aging population that unfortunately are taking up drugs more and more and in surprising numbers. We have the mental health colleagues to look at the overlap of substance use with mental health conditions. So this really is an all-hands-on-deck situation for us, and I'll show you some of the resources that we've been fortunate enough to have leaders like Hal Rogers in Congress to allocate to NIH to address these concerns. Now, I'd like to start out with these maps, because this tells a really important story. First off, you can immediately appreciate when you look from the left to the right that the heat has turned up. You see this, that every part of the country has seen an increase in the number of deaths related to drug use over the last 20 years. But you also notice the second factor. These issues are not evenly distributed around the country, and some areas are particularly hard hit. What I was intrigued by is that even when you look back 20 years before much any of us were paying attention to this, we actually saw the sparks of a problem in this part of the country. And so I think if we'd been paying attention 20 years ago, we might have turned this around long ago instead of having another generation impacted and tens of thousands of people, or now hundreds of thousands of people dying of overdoses. The latest full-year data are from 2016 and show over 63,000 deaths. Preliminary information from CDC would suggest that this rate continues to escalate in 2017, with their preliminary data show some 72,000 deaths in 2017. So we certainly haven't turned the corner yet, and we have a long way to go. Now, this is not one epidemic, but it's actually three. So when we think about the opioid crisis, at first, if I'd been here a few years ago, we would have just spoken about prescription drug misuse. And indeed, that was the spark that started this. We had excess prescribing, excess availability, egregious marketing practices, meaning that many people who weren't going to benefit from opioids were actually started on them. And unfortunately, some people that start on this find they like it. We also found due to excess prescribing, there was an awful lot of leftover medication that could then be shared with others, whether that was intentional, giving it to your child because they have an ache or a pain, and then they learn that they like it and want to do it again, or inadvertent when a babysitter or a babysitter's boyfriend or girlfriend rifles through your medicine cabinet and takes it. These are examples of how excess prescribing can lead to inadvertent poisonings all around the country. And that's what these are. These are all poisoning deaths. Now, that was, as if that weren't bad enough, what we've seen in the last decade now is that heroin has followed on the heels of the prescription opioid epidemic. This is also driven by economics. We've seen drug dealers really shifting the way they market heroin around the country, finding ready populations who are using prescription drugs that once they are exposed to heroin may make that transition. Some of the first examples of this were out of Wright State University, where they documented the transition from prescription drugs to heroin now about 15 years ago. So while we've known about it, we actually haven't mobilized all our resources to address this until quite recently. Unfortunately, there's a third leg to this story, or a third component to this story, which is the synthetic opioids. I use the term fentanyl, but that's a little bit of a misnomer, because fentanyl is one of the medications that it can be prescribed and is very important for end-of-life care for some particularly severe cancer pain. We're not talking about the fentanyl that comes from pharmacies. For the most part, we're talking about fentanyl that comes from chemical factories, mostly in China. It takes a pretty involved factory to produce fentanyl. It's not an easy synthesis like methamphetamine, but unfortunately it's very cheap to manufacture, and so it can be then distributed using the Postal Service or commercial carriers directly to drug dealers in the US, or indirectly going to Canada or Mexico and then sort of following the more typical drug distribution routes. Now, why is this such a problem? Fentanyl is particularly potent, and so a very small amount can poison people. The way I like to explain it is it's estimated that it may be up to about 50 times more potent than heroin. Well, 50 times is an abstract notion, but for those of you who are cooks, if somebody poured a cup of absolutely pure heroin out, you'd be kind of horrified and would realize, oh my God, think of all the people that could be poisoned by that large mound of white powder. Well, how much fentanyl would be the equivalent of a cup? About a half a teaspoon. 1/2 a teaspoon, a tiny amount of white powder, can have the same poisoning power as a cup of heroin. So that gives an example of how you can imagine that people don't necessarily know how much they're getting. Also, some drug users will intentionally seek out fentanyl, believing that because it's more potent, they may experience the high that they haven't experienced in some time. It's a very frightening situation, as reflected in these numbers that show the skyrocketing overdose deaths. Now, I'm just going to end by highlighting what we're doing at the NIH to address some of this. We're embedding these issues in terms of the broad department-wide effort to focus on prevention, changing prescribing practices, developing new medications to treat pain that aren't opioids, that don't have the dreadful side effects that cause so many poisonings. We're looking at ways to rescue people by distributing naloxone more effectively and getting it out into the communities where people overdose, where people stop breathing, because this medication can bring them back to life. But that's just a rescue. That doesn't bring people into treatment, and that doesn't help them turn their lives around. We need to make sure that we have treatment available on demand everywhere that people suffer from these problems. And that's been a major issue, providing the resources and the systems to make sure that treatment is available. And finally, we need to think about recovery services in terms of not just how do we help people begin to turn their lives around, but how do we help them make that long-term change that's about changing your lives. NIH is very fortunate to have additional funding from Congress this year, and with luck, next year as well, to increase our ability to support research to address all these issues, whether that's new treatments for pain, basic research on pain so we can do a better job of not using opioids, or improving our treatments for overdose and for addiction itself. These are some of the efforts that we're undertaking in collaboration with colleagues at the University of Kentucky and with community organizations represented in this room every day. So I look forward to now introducing our speakers and engaging with you a discussion around not just the national efforts, but how these are reflected in your local situation here in Kentucky. Thank you for your attention. As I introduce our panel, I want to point out that there's a slight change in the schedule. We're going to start out with Emily Walden, who will be our first speaker. And Ms. Walden brings to us a personal story of loss, which really represents the losses that are included in those numerical graphs I just showed you. You know, I mentioned 63,632 or 72,000 deaths in 2017. Each one of those deaths has a story. Each one of those people had family members that loved them, that misses them terribly, that wishes we had been able to do something to help them turn their lives around. And that's the message that Ms. Walden will bring to us this morning. And please join me in welcoming Emily Walden to the stage.
I'm the mother of T.J. Walden. Some of you may know some of the work I've done concerning the drug Opana, and I could seriously talk the next hour. I have the clinical trial data memorized. I could tell you things that's happened from 1955 through the OPANA meeting last year in 2017, but I'm not going to bore you with that information. I was asked to share my story with you about my loss and the impact on families. And after some thought, I would like to include an encounter I had with a young man last year. I was at a stoplight last summer behind a city bus, and a young man was running in the middle of the street trying to catch the bus. The bus driver did not see him, and when the light turned green, he took off. So without even thinking, I pulled up next to the young man and asked him if he needed a ride. He hesitated, but then opened the back door of my car and got in. This was not a smart thing to do. And if anyone here knows my family, please don't tell my father I did this. I'm being serious. It was not wise and also pretty concerning that this boy was wearing a large hooded sweatshirt and sweatpants, and it was 95 degrees outside. But for some reason that day, I offered this stranger a ride. I started driving and asked the young man how he was doing. He immediately became somewhat angry, and he said, "Why did you pick me up? You shouldn't have picked me up." I said, "Well, I kind of thought you needed a ride, and I felt sorry for you because you missed the bus." He said, "You shouldn't have picked me up." I said, "Where are we going?" He didn't answer. So I became a little irritated. And I said, "Well, maybe you shouldn't have gotten in the car with me. You don't know me. Didn't your mother ever tell you not to get in the car with strangers?" He gave me a mean look and went, "Pah." I said, "Where am I taking you?" He told me where, and it was much further than I wanted to go, but I proceeded to drive him. He said, "Why did you do this?" I said, "What are you doing today? Where have you been?" He told me that he had been to the hospital because his leg hurt, and they did not do anything for him, and he did not even get anything for his pain. I said, "Well, I just saw you running for the bus, so your leg can't be hurting you that bad. And besides, you don't need to be taking any painkillers." I said, "Did you know that hydrocodone is almost the exact same chemical makeup as heroin, and you don't need that?" I then told him about my son, TJ, and that he had lost his life at the age of 21. He was a member of the Kentucky Army National Guard. He was funny. He loved his family and wanted more than anything to serve his country. He would see someone with a veteran's hat on, walk up to them, asking them about their service, find out their whole life story, and give them a hug before he walked away. He was the most patriotic young man you could have ever met. TJ had broken his arm at the end of the 4th grade, and they found a cyst inside his bone. So he had to have multiple surgeries throughout his childhood. He was prescribed opioids on and off. When he was about to turn 18, he was offered an Oxycontin with a group of friends. He made a bad decision that very quickly led to an addiction to the drug OPANA. What I did not know at that time was that early exposure to opioids can make you more susceptible to addiction. So when he made this bad decision, it changed his life almost instantly. TJ struggled with his addiction. He told me numerous times, "Mom, I don't want to die from this." And he wanted to live a normal life. I put $11,000 on a credit card to put him in a 30-day program. And at that time did not realize that would not be long enough. I drug tested him, tracked down his drug dealers, put them in prison, took his car away, sent him to my parents' house to get him out of town. I followed him, tried to do whatever I could to help him. All the while, he would respectfully say, I know you're trying to help me, Mom. He went through periods of time where he was doing well, and then you could tell immediately when he was not. He lost his life on a camping trip with friends in July of 2012. A mother's worst nightmare, to have a police officer come to your door and tell you your son will never come home again. The young man in the back seat of my car listened intently and said, "Look." He pulled up his sweatshirt to show me his T-shirt that had a spray-painted picture with writing that said, "Rest in peace." He said, "I lost my brother 4 months ago to heroin." I told him that I was very, very sorry and asked him, "How is your mom? Is she doing okay?" He was quiet for a moment, and he said, "Ma'am, it's bad. It's real bad. She is not doing good." I said, "I know you're hurting, but please, you need to know that us moms, we take this especially hard, and she needs you. We worry about losing our other children. We worry about where you are. You need to tell her where you are. You need to tell her when you will be home at night, and you need to be on time. Please be good to her and be patient." He said, "Yes, ma'am, I promise." He said, "Ma'am, do you think our government is behind this and sending these drugs up from Mexico?" I said, "Well, I don't think so, but our government has certainly played a role in this epidemic." And I told him about the pharmaceutical industry influence over our government and the amount of money spent lobbying our elected officials, $280 million in 2017. I told him how the FDA is supposed to protect public health, and they allowed these pharmaceutical companies to market these drugs inappropriately, influence prescribing guidelines, and modify clinical trials. All of this leading to these drugs being massively overprescribed, causing devastation throughout our entire country. The drug cartels in Mexico simply took advantage of the epidemic that we created. The deaths from heroin, fentanyl, and other illicit drugs are a direct result of the last 20 years of overprescribing, and we will continue to see these effects for years to come. He sat there shaking his head in disbelief. I pulled up to the gas station where he had requested to be dropped off, and he sat in the car for a minute, then slowly opened the door and got out. He stood with the car door open for what seemed like a long time, then leaned back into my car with tears running down his face. And he said, "Ma'am, I bet my brother and your son are friends in heaven." He shut the door and walked away. I don't even remember this boy's name. I'm not even sure I asked him. But I often think of him and his family. My son, this young man's brother, and thousands of others have been victims of the calculated, misleading, lethal actions of the pharmaceutical industry greed and FDA corruption. This is an epidemic of addiction. The deception must stop, and all of us should be demanding the necessary changes to ensure this never happens again. We are, all of us, in this together. Thank you.
Thank you very much. We will have a chance for all of us to engage in discussion when the panelists finish speaking, but I certainly think that was an important way to begin our panel today. Really set the stage for the whole day's discussion. Our next speaker to build on these same theme of issues will be Nancy Hale, who's had a very long career in advocating for changes to communities across Kentucky. And indeed, her efforts have led to national changes. And that's what she and I were talking about when I was having a cup of coffee this morning about how her work here in Kentucky has led to, first, the recognition of this as a problem of rural health, and then and finding ways to address this both locally and then take that message all across the country so that other communities and other areas don't have to suffer all the same consequences, but might be able to learn both from the devastating consequences here in Kentucky as well as the hopeful changes that Ms. Hale represents and brings to your communities. With that, please join me in welcoming Nancy Hale.
Emily's story brings home the harsh reality of this, because every day we are bombarded with horrifying headlines and scary statistics about this drug epidemic. And those are the harsh reality. But I'm here today to share with you about how organizations working with community members are creating hope in the midst of this and saving lives. My name is Nancy Hale. I'm an educator. I'm the mother of a son in long-term recovery, and I'm President CEO of Operation Unite. Unite stands for Unlawful Narcotics Investigations, Treatment, and Education. In 2003, Unite pioneered a three-pronged approach that has become a model for other states in the nation. Law enforcement, treatment, and education efforts all work together in a collaborative model to prevent abuse of drugs and facilitate recovery. That is achieved by creating strategic partnerships, providing leadership, promoting education, coordinating treatment, and supporting law enforcement. But the heartbeat of our efforts is our county coalitions. It used to be that youth programs were geared only to help young people avoid the dangers of the streets. But for many of them, that danger is much closer. It is at home. That is why we have volunteer community-based prevention groups to implement education, awareness, and recovery initiatives within each of our counties in the 5th Congressional District. And the Bright Spot Awards, McCreary and Wayne, are part of our coalitions. They provide education as well as support treatment initiatives and investigations. Coalitions retain their own identity, but they all help build a safe, healthy, drug-free community. Guided by Unite staff members, these grassroots organizations, they're all 501c3 nonprofits, engage their communities to address local issues and support those in recovery. These homegrown volunteers know their communities. They know the problems. They know what works, but they need to be empowered. And it's a two-way street. Our coalitions and Unite work together to exchange information and invest in needed programs. That collaboration is continuous. Each of us enhances the work of the other. Our connection with the community coalitions helps us organize education efforts in schools. We collect data, we determine best practices, and freely share it back with those stakeholders. It's an evolving process. I'd like to share just examples of 3 of our counties, how they're attacking the problem differently and providing solutions tailored to their citizens, and how the umbrella of Unite is maximizing the investment. For the last 14 years, Knox County Unite Coalition has brought together people from their county, 12 different sectors within their county, with the common goal of fighting substance abuse. And those members are making a difference. According to the biannual Kentucky Incentives for Prevention, or KIP survey of youth in grades 6, 8, 10, and 12, there's a decline in drug and alcohol use. Their coalition provides prevention education at youth activities with a safe, drug-free environment. They believe that helping the young people focus on skills such as playing basketball, playing soccer, archery, fishing, golf, cheerleading, that they're learning lifelong skills and discipline. And these young people see adults in leadership positions taking an interest in them, serving as role models in their lives. The community views Knox County Unite as a source of help in terms of treatment, education, prevention. Their members receive drug tips to pass along to law enforcement. They share the Operation Unite treatment referral line. They give families a list of treatment facilities. They provide youth activities and education. They hand out schedules of AA, NA, Al-Anon, Celebrate Recovery meetings. And sometimes they just serve as a listening ear to a family member when they break down emotionally and need support. The Coalition credits these activities as a positive factor in its application for a Drug-Free Communities grant, and Knox will begin its 10th year of the grant in October. As a result, the Coalition has been able to fund more activities, media campaigns, educational events, town hall meetings. Claudia Greenwood, who is the Knox County Unite Chair, says, "The community perception of Knox County Unite has gone from being a group that locks up drug dealers to a group of people who care about individuals in the community and are trying to make a difference." In Rockcastle County, Coalition efforts are built around the school system, while over in Clay County, they are leveraging popular outdoor adventure activities such as canoeing, kayaking, archery. They're working with tourism to provide safe, healthy activities that also are paired with drug prevention education. From faith communities to law enforcement to educators to families, we all have a stake in combating this epidemic. So we must all take on some of the responsibility. There are several initiatives that can support you in all facets of the epidemic. Our partnership with the Kentucky State Police in the Angel Initiative helps people before they reach the justice system. A person with a substance use disorder can voluntarily walk into any of the 16 KSP posts in Kentucky and ask for help. If they do not have any criminal charges pending, they will be paired with a volunteer angel who guides them through the process of obtaining treatment. Where do we find those angels in the 5th Congressional District? In our community coalitions. We realize, and just as importantly, law enforcement realizes, that we are not going to arrest our way out of this epidemic, even though those arrests may garner the greatest headlines. Secondly, take-back efforts are saving lives. Did you know that among new abusers of pain relievers, 68% obtain those pills from a friend or a family member for free or without asking? People must have a way to dispose of unwanted pain medication safely and without harming the environment. So our coalitions have placed prescription take-back boxes at law enforcement offices in our 32-county service region. We have 42 of them. We have collected more than 11.8 tons of medications. Now, how much is that? Think about the UK win Saturday. That's enough to cover half of the football field at Kroger Field. Not every county in Kentucky has take-back locations, but they all need them. In addition, our treatment line fields approximately 1,200 inquiries each month in our 32-county region. Trained staff help those with substance use disorders, help their families find out about options. And the need was so great that last December, as part of Governor Bevin's Don't Let Them Die campaign, the Kentucky Help Statewide Call Center for all Kentuckians was launched, and Unite is proud to staff that center. There are a lot of other initiatives that I don't have time to discuss, but I'd be happy to answer questions about. Our work with the drug courts and the administrative office of the courts. Our Hope Wall, which features people who are in long-term recovery. Our Give Me a Reason test kit program, giving parents another tool to have in their toolbox to help their children refuse drugs. But to make progress, we not only must cut off the supply, we must decrease the demand. Offering youth alternatives to drug use through programming and hands-on education makes a huge difference. We have to give them the facts. We need children to understand how to make healthy, not harmful decisions, and that lesson starts in kindergarten. Repetitive, consistent messaging is essential. Our prevention initiatives include mentoring and nurturing components that guide youth away from destructive choices. And thus far, We have reached over 230,000 students through our school-based and summer initiatives. One important component is our nationally recognized AmeriCorps initiative. 54 full-time members who provide math tutoring and drug abuse prevention education in elementary schools. An evaluation by the University of Kentucky for the last school year showed that those math test scores increased 56.5% among the students who received that tutoring, and drug education and healthy decision-making knowledge increased 51.4% among the students receiving that curricula. By educating children, we enable them to help their parents or caregivers. One parent sought help for her addiction after her fourth grader told her about Unite and what she was learning in her Too Good for Drugs class. There are many other initiatives that we have in the 5th Congressional District. I can share information on you. She's holding up a sign telling me how much time I have left here. So I want to go on. One of our most successful programs, though, I have to mention, is our Shoot Hoops Not Drugs basketball camps that we do each summer with Jared Polson. Something for the parents and for those children. But the greatest opportunity for hope lies with you. Each one of you in this room has a responsibility. You have a responsibility to be part of this solution. Each one of you can be that light that shines the way forward. We're on a journey here in Kentucky, from help to hope to healing, and we will get there, but we must get there together. First, by taking responsibility within our own communities, identifying the most pressing needs, and developing strategies to solve those needs, and by always keeping the focus on our children and youth. If Unite can ever be of assistance to any of you, please give us a call. Together, we can turn statistics into success stories. That's the responsibility that we have.
Well, thank you very much. From help to hope to healing. I think that's a wonderful catchphrase. I appreciate that. We're going to shift gears a little bit now and focus on one of the key ways to help people turn their lives around, which is by integrating treatment into services that people receive. And Dr. Scott Teitelbaum is our next speaker, and he brings a wealth of experience from the University of Florida and his long-term work with both professionals and other persons with addiction, really bringing a message to me and to other clinician scientists that it's not the short-term treatment, but it's thinking long-term about how we help people turn their lives around, because they didn't get into these situations overnight, and it takes more than a short period of time for people to really embed the recovery message into their lives. And with that, I'll ask Dr. Teitelbaum to join us.
Thank you. First of all, I didn't think I'd be coming to Kentucky with the Wildcats ranked ahead of the University of Florida. I don't know how that, yeah. Okay. All right. So I know I only have a short period of time in treatment. I could speak a long time about treatment. I want to talk about just some fundamentals of establishing effective treatment. The first thing to consider is that, keep in mind, only 1 in 10 people that need treatment receive it. And of those that need it, 95% of them think they don't need it. It's a hard population. Denial is rampant. Not because Dr. Compton is here. I looked and I said, one of the great ways I could summarize this is in looking at NIDA's 13 principles of effective treatment. Of course, I'm going to add a 14th, but they might not listen to me. Number 1, no single treatment effective for all individuals. Good treatment should not be a this or that. It should be a this plus that. Number 2, treatment needs to be readily available. When people call and people put on a waiting list for treatment, that's not how the illness works. If you need treatment, you have to receive it at that time. Waiting lists don't work. It has to be available, and available locally. 3, effective treatment needs to address multiple needs. Many of our people that come to treatment for substance use disorders have co-occurring mental health problems, histories of trauma, medical problems. There's multiple needs that need to be addressed. Number 4, flexible. There was a time in our treatment industry, we had a 28-day program, we had a fixed length of time. Treatment needs to be flexible, looking at the individual's needs. Number 5, treatment needs to be adequate period of time. You need an adequate period of time. I hope people here in the insurance industry are paying attention to this. It's frustrating to treat people and have people with 10 and 15 years of IV opiate addiction and to be talking to an insurance provider on day 8 to move them out of treatment into a lesser level of care. That's a hard conversation. As a matter of fact, they don't let me on the phone anymore. Number 6, individual and or group counseling and other behavioral therapies are critical. I know there's a great emphasis, and it's going to be number 7. We're going to talk about medications, but good treatment involves individual and group therapy. There's a lot of power in group therapy. Sharing, shame reduction, sharing pain. Recovery is really about a balance of pain and hope. Pain to drive people to want to live a different way of life. You need enough pain to change. I have an old mentor that used to say people don't change until the pain of their illness outweighs the pain of change. Painful to change, and groups facilitate that. Number 7, medications are an important element of treatment for many patients. This has become somewhat controversial in the field, and it really should not be. But, Dr. Greg Jones, my good friend, was here, and we were talking. One of the medications that doesn't get a lot of attention is Vivitrol. People a lot of great debate about methadone and Suboxone, but opiate blockade. And recently we've learned, and we've learned this we did some research at the University of Florida looking at healthcare professionals, but now outside of that area, medically assisted treatment, Vivitrol, opiate blockade, is very efficacious and needs to get a little bit more attention. But people providing medications is an essential part of treatment. And Narcan, when I went to medical school, breathing was good. I know I'm old. I just turned 61, but I still think that's the case. Rescue is important. You got to keep people alive to receive treatment. Number 8, addicted or drug abusing individuals with coexisting mental health disorders need to have both disorders, all the disorders, treated in an integrated way. You've got to integrate things in treatment. You can't compartmentalize. And this drives me crazy in the Department of Psychiatry. I have so many people in our own department in psychiatry that don't pay attention to the substance use disorders. They pay attention to the other things, the depression and the anxiety. And conversely, people in addiction need to look at things, look at trauma, look at family of origin issues, look at co-occurring depression. Matter of fact, there's some recent data that suggests that many of the overdoses perhaps are suicide attempts. Number 9, medical detox is only the first stage. Detox is about giving people, allowing them to have their withdrawal treated effectively. The irony is for opiate withdrawal, it's not very medically dangerous unless you have some coexisting other medical conditions. So it's hard to get people detox in a hospital setting. But detox is only one very small part of treatment. It's only the beginning. And actually, if you just detox people, nothing else is going to happen. Number 10, does not need to be involuntary. We've learned this with healthcare professionals, and we learned it in drug courts. Often initial motivation is external. Effective use of leverage. Bob DuPont, who's a dear friend of mine, actually the original director of NIDA, always talks about effective use of leverage is good. And it's easy with healthcare professionals, easy in drug court, but there's other modalities too. If you have a 20-year-old and they want their car insurance paid or they want college, leverage can be used effectively. What you're hoping is that the initial motivation might be external, but in time, the heart will follow. You'll have internal motivation. 11, possible drug use during treatment must be monitored. I would amend that and say drug use needs to be monitored not just during treatment, but after. We follow diabetes and hypertension. We don't treat diabetics. We're not going to test your blood sugar. It's a violation of your, my patient, relationship with you. It's going to affect our therapeutic alliance. No children, when I practiced pediatrics, ever said, "Don't poke my finger. It affects our therapeutic alliance." I had the nurse do it anyhow. But monitoring drug use and alcohol use is critical, and not just early on throughout the recovery. Treatment programs assess for HIV, TB, other infectious diseases. I would amend that. All illnesses. When we have our medical students at the University of Florida, and our rotation is a mandatory rotation for medical students, whether they're going to be in OBGYN or psychiatry or family medicine, it doesn't matter, because everybody will see this illness. But we'll always ask the medical students, alcohol, there's not an organ system it doesn't affect. You need to pay attention to medical conditions all the time. 13, recovery from drug addiction can be a long-term process. It is. And I would add number 14, and nobody's going to listen to me, but I would say that mutual aid programs such as Alcoholics and Narcotics Anonymous should be strongly encouraged. You can't understand the history of addiction medicine if you don't understand the history of the involvement of the 12-step movement in the 20th century. So I would add that. I think it's a forgotten tool. When we assess people, we look at 6 dimensions, and we look at briefly, thank you for the note there, acute intoxication and withdrawal, for levels of care, how intoxicated they are, do they need to be separated from their drug. We're looking at these 6 dimensions: dimension 2, medical conditions; dimension 3, emotional, behavioral, and cognitive conditions, including family of origin issues, trauma, shame; dimension 4, readiness for change. Most people, I told you, come in externally motivated. That's not uncommon. You've got to try to find a way to motivate them to get their heart to follow. Relapse potential, number 5, in dimension 6, recovery environment. Where do they live? Do they have legal issues? We look at these dimensions, and then we come up with kind of a risk rating for each of them. So I'm going to buzz through. I'm not going to talk about the features of the placement criteria, but it's a way to look at every individual patient and figure out a level of care. Okay, and it's a multi-dimension and looking at psychosocial and biological systems and looking for a continuum of care. And it's individualized as opposed to a 28-day program or a 90-day program. And the decisions that made should be driven not on financial, although that's a reality. It should be clinical, the recommendations. And these are the multiple levels of care. And you can see you start from early intervention and prevention, opiate treatment programs, all the way down to inpatient. Okay? And so there's multiple levels of care. And you have to be flexible moving people across levels. If you can't do that, you're going to struggle because not everybody will need that same level all the time. In other words, somebody might be moved to partial hospitalization or residential, and they might relapse. They might need to go to a high level of care. They might not need to. But you need to understand and know where your different levels of care are at. I talked about the risk rating. I want to spend the last couple of minutes talking about a Kentucky program, Recovery Kentucky. When I was coming here last night, Dr. Jones had sent me a slide, and I started to look and I started to read. This is a fascinating program that other states should look at. You can see right here in Lexington that you would have, I think it's Hope. Which one is the one in Lexington there? Center for Hope. And so when you look at these programs, they provide a milieu. One of the things in the dimensional assessment that we've struggled with, and we're looking at medical decision making, is recovery milieu. That's being in an environment with other recovering people. And I understand everybody can't afford the different levels of care, and I understand that insurance will not always reimburse this. But this has been a great collaboration of the Department of Corrections and the Department of Housing to create a milieu and an opportunity for people to be together and to work on recovery and kind of a safe milieu with a lot of 12-step involvement. And we were talking last night about them looking at the use of medically assisted treatment and things like Vivitrol and other modalities to help. And I think that if every state, and I know I'm in Kentucky, and this is a rather unique program. We don't have, I can tell you this in Florida, we have nothing like this. So I think this is going to take a great effort. It's going to take a grassroots effort in all the states. And I'll repeat, I was touched listening to Emily's story, and as a father of 5 children that go from 31 to 5, so I have to work a long time. And I told you, my original career is as a pediatrician, and there's nothing harder than watching somebody you love, especially a child, suffer or die. And recovery is possible, and I know our next speaker is going to address that. But there's a lot of pain out there, but there needs to be hope also. And I really thank everybody for having me, and I finished somewhat in time. Did I not? Thank you. All right.
Well, I'd say the National Institute on Drug Abuse would be very interested in expanding our list of essential services for treatment, and certainly recovery is a key part of that. We think that's embedded in some of our recommendations, but those haven't been visited in a number of years, so it's time for us to take a look at that and think through how we really go from this idea of addiction being a chronic illness to actually putting that into practice. We were talking about that over coffee earlier this morning, and for a long time, clinicians have paid lip service to the idea of addiction is a long-term condition. It needs to be thought of in chronic ways. But yet our treatment was still organized in terms of short-term little treatment episodes, rather than thinking, how do we care for a patient over their life course, whether that's with inpatient care, with outpatient care, or recovery support services when they're reasonably stable and back in the community. That's an issue that Alex Ellswick has been addressing both with his professional work, I think some of his personal work as well, and certainly with his PhD work here at the University of Kentucky, to focus on a burgeoning area of science and research on how can we do a better job of integrating recovery support into everyone's everyday lives so that we can help people really go from treatment to long-term turning their lives around. With that, please join me in welcoming Alex to the stage.
Well, good morning. I decided to forego slides so that you can keep your attention just right here on this pretty face. I saw a meme on Facebook not long ago that said, if you're the kind of person who describes your life as a journey, you probably have a DUI. And my life has been quite a journey. I'm a PhD student at UK and also a co-founder of a local nonprofit organization called Voices of Hope. And we take people who are in early recovery and help them sustain their recovery over the long term. But most importantly, I am myself a person in long-term recovery from an addiction to heroin and pain medication. And oftentimes when I do speaking engagements, people approach me afterwards and they say just the kindest things. And they say, Alex, we're proud of you because you're so strong, and you're so brave, and you're so resilient. And I desperately want those things to be true, but the reality is that they're not. The reality is I'm not in recovery today because I pulled myself up by my bootstraps. I'm not in recovery because I wanted it more than someone else. I'm not in recovery because I was willing to put in the work, or whatever post hoc narrative we come up with. They're not true. The reality is I'm in recovery today because I got access to the resources that I needed to treat my disorder over the long term, right? And so we talked about, Dr. Compton talked about addiction as a chronic disorder, and we do pay lip service to the idea. Because every definition, from the NIDA definition to the ASAM definition to the DSM-5 definition, has at least a tacit acknowledgement of the fact that addiction is a chronic disorder. And so like other chronic disorders, whether it's hypertension, heart disease, or diabetes or asthma, they have to be treated on an ongoing basis. And yet, we continue to pay lip service to the idea because our existing paradigm for treating addiction is what we would call an acute care model that's characterized by things like crisis stabilization and most often short-term treatment followed by nothing. And if you think about it, you know what I mean. We send somebody to treatment maybe for 30 days, maybe we send them to treatment for 6 months or even a year, and that's fantastic. That's going to improve somebody's rates of recovery. But what do we do when they get out? Most often, we hand them a pamphlet with a list of either 12-step meetings or resources in the community, and we say something cheeky like, don't think, don't drink, and go to meetings. And that's fine, and for some people that works. For some people that's sufficient. But the reality is it's not sufficient for most of us, and that's evidenced by relapse rates that are far, far too high. And if you conceptualize it for a second, that's the obvious result. If you have a chronic disorder and you continue to mismatch it with an acute care model, the inevitable result is long periods of time in which people are not managing their disorder. So it shouldn't be surprising that people relapse at the rates they do. And what's really awful is then when people relapse, we shame them when they show up back at our doors for treatment or at a hospital. And we say, you're a frequent flyer, and you must not have wanted it badly enough. And that's not fair. And what really drove this point home to me was when I got to UK and I started doing research for my master's and my PhD, and I stumbled upon a concept called recovery capital that I want to share with you. But before I do, I want to tell you about the article from which it originated, because I think it helps paint the picture. In the mid-1990s, a gentleman by the name of Dr. Granfield published a manuscript called The Elephant No One Sees, Natural Recovery Among Middle-Class Addicts. And quickly, as an aside, I'll tell you, I abhor the word addict. There's a long, long line of research that suggests that word's stigmatizing and is harmful to people like me. But that's a discussion for another day. This is just the title of the article in the mid-1990s, Natural Recovery Among Middle-Class Addicts. And what Dr. Granfield found is, first of all, the elephant that no one saw is that fully half of people who are in recovery today got there without formal treatment. Now, does that blow your mind? Because it blew my mind, to the point where I had to go and fact-check it over and over again. Now I see fully half of people who are in recovery today got into recovery without formal treatment. That's what we call natural recovery or natural remission. And in particular, this is a phenomenon we see among middle class and upper middle class folks. And so very much in the spirit of the Bost Forum of looking for solutions, Dr. Granfield said, let's look at what's working there, because there's something that we can glean from that, something we can learn from that reality. And it launched this entire line of inquiry into the study of what's called recovery capital. And recovery capital you can think of like other forms of capital, whether it's financial capital or social capital. It's a reference to resources, but in this case, it's a reference to resources that people can leverage in order to support their recovery from a substance use disorder. So it's most often divided into three key domains: personal, social, and community recovery capital. So personal recovery capital encompasses all things intrapersonal. So it could be something like having vocational skills, having some level of education, could be the state of your mental health. Do you live in a stable home? Do you have stable employment? All of these things that we know are correlated with better recovery outcomes, and that people can leverage when it's time to enter or sustain recovery. Social recovery capital involves all things interpersonal, all things relational. What's the nature of your family relationships? What's the nature of your relationship with your partner? What's the nature of your social network? What's the nature of the quantity and quality of these relationships? And are they supporting or are they hindering your recovery? And finally, and maybe most interestingly, is community recovery capital. Because essentially it suggests that the time and place in which a person is trying to recover may dictate a lot about their outcomes. So for instance, trying to recover in Fayette County versus in an Appalachian community like Pike County may be a very different experience, right? Folks over there may experience rural health disparities and may not have access to the same resources that people here have access to. Similarly, trying to recover in 2018 may be a completely different experience than trying to recover in the year 2000 when medication-assisted treatments were much more stigmatized than they are even today. So recovery capital is what people need following treatment. Instead of handing somebody a pamphlet, we need to find ways to increase their recovery capital, to give them resources they can leverage to sustain their recovery. And this is essentially what our organization tries to do. We didn't want to reinvent the wheel, and there are already so many great folks like Recovery Kentucky who are doing work in treatment. So we want to pick up where they leave off, have a warm handoff, and pick up when someone leaves treatment and see what barriers need to be removed for them to sustain their recovery. And this looks all kinds of different ways. We have a program called Telephone Recovery Support, and the beauty of the program is in its simplicity. Basically, volunteers, most of whom are in recovery, make weekly phone calls to people in recovery just to check in and say, how's your recovery going today? And how can I help you with your recovery today? And it's augmenting their social recovery capital, making it easier for them to maintain their recovery. We're piloting a program that Dr. Fallon Bennett, one of our board members, has created that's an internship program, because we know that many people in recovery have criminal records, have gaps in employment, don't know how to build a resume. And so what we're doing is, one, we're employing people 10 hours a week on a rotating basis, and as a part of the time that we're paying them, we're actually requiring them to go seek services to learn how to build a resume, to learn how to conduct an interview, to improve the likelihood that they'll be employable in the future. We're starting, it's been a long, long process, but we're about to open a recovery community center here in Lexington. And it's not a treatment center. We don't provide clinical services. The entire idea is that this is a place for people in recovery to grow their recovery capital. So maybe you come to a 12-step meeting. Maybe you come to a yoga class that's free. Where do you get free yoga? You know, I mean, come on. Maybe it's not like goat yoga. It's not fancy bougie yoga, but it's recovery yoga. Maybe you come to a class that teaches you how to go about, let's say, expunging your record, or working with DCBS to get your children back. And all of those things are such overwhelming processes. So then we're going to have recovery coaches who will be certified peer support specialists, whose job will be to work with people on a one-on-one basis to help them overcome these barriers to recovery. So the point is this. I tell people oftentimes that there's a difference between sobriety and recovery. Sobriety is about what you don't do. Sobriety is about not using drugs and alcohol. But recovery is about what you do instead. It's about the ways that you grow and that you flourish and that you lead a happy, self-directed life. Sobriety gives you the skeleton and the bare bones to live, but it's recovery that gives your life sort of a third dimension and a depth and a weight and a meaning. And I'm grateful to be in long-term recovery, but I know that it's only because I had access to what I needed. And so it's my hope and my wish that that we'll make an effort to create a continuum of care where we fill in the gaps and we provide people access to all of the resources that they needed. Because I'll finish by saying this. My best friend on this planet since I was 2 years old is named Bobby. I love this kid like a brother. And right now he is at Fayette County Detention Center on cocaine charges. And I promise you that beyond a shadow of a doubt, I believe if he had access to what I had access to, he might be standing up here wearing a suit instead of wearing an orange jumpsuit at Fayette County Detention Center. Thanks.
Well, thank you very much, Alex, and thank you to all the panelists. This is an opportunity now to open it up for discussion. We've addressed a really broad range of issues from the personal impact of overdose on families, the ways communities can organize, a smattering of information about how treatment can be organized, and also about the importance of long-term perspectives and recovery support services. I'll be curious now what questions you have about how to implement some of these best practices and some of these ideas within your area, or any other topics that you'd like to discuss with the panelists this morning. Please use the microphones around there, and we wait for your questions. Yeah, go ahead.
My name is Ann Roberts. My son died summer of 2013 of a suspected heroin overdose, although we're not really sure because he went into the bathroom to cut himself. And the coroner, who is running again, refused to do an autopsy because, he's one of those drug addicts. I have worked in addictions as a social worker and a nurse practitioner since the O Narcotics Farm used to be here in Lexington. So this has been a long history of my working in addictions. I've worked in a methadone clinic. I would just like to ask if there's anybody from the Fayette County Police here today. They need to be. If I sound angry, I am. I wish Alex had been here in 2013 because my son would have related to this young man. There is not a day that doesn't go by that I don't relive what I should have done to protect my son. And yes, I see all this up here. The only person that I heard speak about a long-term illness was Alex. So you all need to put things in everyday terms. Yes, this is an ongoing illness. And talk in regular terms. When I worked at the methadone clinic, this stuff had already, some of this had come up. I went to my church not too long ago at St. Michael's, where I hold a GRASP meeting every month. I don't know if any of you have heard of that. It's for the parents who have lost a person to substance abuse. They are all hurting because they have seen all this. They've read all this. It is not available in Fayette County except by Alex. So we can have all these meetings that I've been to for 30 years, but it's not getting to the public. It's just not. Not until you get the Fayette County Police here, not till you get the coroner here, not till you get people here who are there, the first responders. I tracked down the 3 people that were with my son the night he died on my own. 2 of them were the girls that he went to his 128-day stay. And they followed up in NA. But I already knew NA was not really good because I used to drive patients from Charter Ridge to the ones that didn't sell drugs outside. I knew which ones didn't sell drugs outside. Okay? This is still going on. This is first-line stuff that people need to be looking at. And I applaud Alex so much, and I'm in awe of this young man for what he's doing. And yes, I'm sure it is hard. It's hard every day. I will end with, last summer, I went to my church to listen to what the police could do in the community, not about drugs, but just about turned over waste cans and dogs barking. A lieutenant from the Fayette County Police Department started off with, you know, we could do a lot more work for you all if it wasn't for these drug addicts. Now that is my daily life.
Thank you very much for adding to the dialogue. I'd like to turn that into a question, at least for Ms. Hale, about how you've gone about engaging law enforcement as a key partner in community action, because that was a key theme and something that you saw was missing. So I'm wondering if you have some insights that might help us.
I think respecting the job that our law enforcement has to do, but helping them, and we've seen the change in them as far as how they can assist and be a part of this, not just by arresting, but getting them involved with the treatment aspect, getting them involved with education and prevention programs, and reaching out to them. Many times, that change is brought about by a tragedy within their own lives or within their ranks, a fellow officer who loses a child and deals with it. One of the things that we've done is having them involved in the community coalitions and having the coalitions understand that these people need to be educated as well. I have a great deal of respect for our law enforcement officers, but I also believe that with programs such as the Angel Initiative, that we're beginning to see them take a role in providing treatment. And so I think it's it's a very simple thing that we did that I think brought about a huge change, and that was with a summer camp that we have called Camp Unite at the University of the Cumberlands, is having law enforcement officers who are there for a week to interact with the children, and they begin seeing the need for prevention, and they begin seeing, that not everyone has to be arrested. When Congressman Rogers when Congressman Rogers helped create Unite, there were a lot of people who said it won't work because law enforcement will not work with treatment. Treatment won't work with law enforcement, education and things. But the day one of our detectives walked into the treatment office and said, we're getting ready to conduct a big roundup in a certain county, and there are 3 men who do not need to be arrested. Help me help find treatment for them. My heart breaks for you, but I think that we have to continue working with law enforcement. We have to continue working, helping Alex. Those people offer that story for recovery, and that there is hope. And I think all of us need to be held accountable.
Well, would you be willing to approach the Fayette County Police and ask them to take my phone calls? I have it on record that they will not speak to me.
Well,
They no longer want to talk about this issue with me, okay? So this is the third thing I've been to, and no Fayette County policemen are here. At least I don't see any in uniform. I don't see Detective Bowles. Where is he?
Alex, you live here? No, I think, I think we all have to be, I think we have to be consistent in our messaging. And, I think that they're going to do everything they can. I truly believe that. But we have to work with them constantly.
I think you've made a very clear point, and the importance of collaboration. Also, what you're talking about is a culture change within law enforcement, which doesn't happen consistently across all locations at the same time. We see sort of pockets of real change, and we hope that that will spread across the whole country. And it's not limited to the examples you're talking about, but there's some very forward-thinking law enforcement collaborations and some less forward-thinking. I'll be polite and say
Dr.
that.
Compton?
Yes.
I'd like to add, it's and I was moved by that, but we can't forget that this is an ugly illness, and I don't come here to talk about myself. I sit up there I have a lot of little titles and a fancy name. I'm 22 years in recovery. It's an ugly illness. We hurt people, mothers, fathers, sisters, brothers, children, and our actions are not pretty when using. And that I have a dear friend that I trained. And he'll send me a slide every month, and he'll make up a number, reason number, whatever, why this illness will never be considered like other illnesses. And it's something ugly, a kid dying of an overdose, finding his parents' heroin. And I think we have to embrace that. And I think part of the solution is to have recovering people work with law enforcement. But while using, it's an ugly illness. So we can't get away from that. It's not pretty. People are hurt. And
Let's turn over to this microphone. Our award-winning questioner right now.
Thank you so much. My deepest sympathy. That's hard to listen.
If you could get close to the microphone.
That last story was very difficult to listen to by everyone in here, and I can't imagine living it every day. Anyway, I've had several conversations with Nancy Hale about this, but I am convinced that prevention is a huge, huge part of this that we don't really address enough. I'm talking about curricula in schools. I'm talking about teachers. I'm talking about parents. Down in Paducah, we're working on that, but I think that if we don't stop the pipeline before all this stuff starts, we're never going to get there. So I think we need to really address curricula in schools, teachers, and get the parents to understand, they're a huge part of this problem.
I will lead off the discussion. I'm sure some others will have some comments. There is actual data to show that the middle school curricula can be useful in reducing the onset of prescription opioid misuse, and so changing these long-term trajectories. We now have 3 large-scale community-based trials that show that either the Strengthening Families Program 10 to 14 or life skills training specifically have had an impact. There may be others, but those investigators in Iowa and Pennsylvania studied that very issue. There are a lot of other projects that look at how to do prevention for young kids and try to change their lives over the long haul, but we don't have the long-term outcomes to look at who uses opioids and who doesn't. So that's a gap area in terms of research, but there is some hope for that very concept you're talking about. Any other comments about primary prevention or something before treatment?
Well, I would say this. I've participated on 2 proposals to try to bring those 2 programs, Strengthening Families and Life Skills, to Lexington, to Fayette County school systems. And certainly prevention is the best cure, but they need to be evidence-based prevention programs. I think one of the things that I resent about the way that we approach addiction is that all of a sudden everybody's an expert. In a way, if I had a cardiac problem, none of you would come up to me and tell me how to treat my heart-related condition, right? That's totally ludicrous. But all the time we have lay people giving people advice on how they should treat their addiction. And the same thing for prevention. We know what works and we know what doesn't. So I'm completely on board with prevention, but not scare tactics, not one-off, that kind of thing.
Amen.
Thank you.
Dr. Compton, could I just say something briefly too? Along with exactly what Alex is saying, is it has to be evidence-based, but we've got to start early enough. And for us in Kentucky, we've seen that middle school is too late. There are K through 12 programs that are developmentally appropriate, evidence-based, culturally appropriate, that build a foundation. And that's what we've got to have in this state. We're making great strides, Dr. Compton, but we're doing in little pockets. And this needs to be something that is statewide, K through 12.
Alex, thank you for your point in the way we approach addiction, as far as we still use the acute model as opposed to chronic. And until we get that, we're going to keep spinning. So I guess my comment is also, when you talk about recovery capital, spot on. It's all about connection. The things we know, the people that are in our circles that support us, or those folks that are in recovery, when we look at diabetes and how we approach that, and the coaches that are there for people when they are dealing with diabetes, we don't have that. We kind of poke at it, but as far as insurance, both ends of the spectrum, prevention, we don't really pay that much attention to, because number one, it's expensive, but it works. So putting our money where our mouth is very important. And then the other end is supporting those people who get out of treatment, and that's when they need the most support from all of us. But we just like to pretend that they're fixed, and in fact they're not. So the challenge to insurance companies is, let's put our money where our mouth is so we can get out of this and support coaching, touching bases with people, that connection that someone cares, because folks in recovery are really good at isolating themselves. They do awful things. They're really excellent at isolating themselves, but that's exactly what they don't need. But that's what we do. So the challenge, I guess, it's not really a question, but I think that's the point, is bringing them back into the community. And we don't do that. As a matter of fact, we shut them up, anonymous. We make them anonymous.
Thank you for your comments. We'll make this the last question, because I would give him the wrap up, and then I want each of the speakers to say a last word.
My name's Amanda. I've been working in this field for 20 years, so I'm well aware of the problem. I'm looking at solutions. So I know that, Scott, you brought up the efficacy of Vivitrol. Do you all see, we know that there is an issue when you can get access, it's hard to get access to treatment sometimes quickly, and that's one of the most important things, and barriers to treatment. With prior authorizations, I don't know if they have this in Florida, because I understand some of our surrounding states don't have this, but Kentucky has a prior authorization on medications, addiction medicine. And so do you see that lifting prior authorizations to be a quick, easy solution? Because we know sometimes people have to wait a day, 2 days, 3 days, 4 days, and that could be someone's life.
I think that's a great point. And yes, it's a barrier. It makes you want to give up. It takes an inordinate amount of time if you run an office to get prior authorization, and sometimes you're declined. And I do think lifting that would make a great difference, because it's a barrier, and it stops treatment providers from wanting to go through the headache of engaging in prior authorization, and it stops people from getting help. I think that's a great point.
Do you all have that issue in Florida?
Oh, yes.
Okay.
In a big way.
These issues vary from state to state, so I'm glad you bring that up, because the way that either Medicaid covers or doesn't cover different individuals in terms of coverage for buprenorphine, methadone, or naltrexone varies considerably. Private insurance also varies, but in general is a little bit easier than some of the others, but many people don't have access to that. So this is an ongoing, very serious issue. I know that we have some state authorities here, and I hope you'll ask some of those questions in the next panel as well, because I think that would be very timely. I want to turn now to each of the panelists and give you just 30 seconds to say any wrap-up comments before we end the morning session.
I guess the last thing I would say is I'm a huge Tiger Woods fan. And, when Tiger started playing well again, everybody was abuzz and everybody was on board. But how many people were riding with him when all the stories were coming out, when he got the DUI? Because I've been on the bandwagon with Big Cat all along, all right? And I say that because I think we have a tendency in our society, we love a comeback story. Everybody likes to get behind somebody who's in recovery, and that's fantastic. And I'm genuinely grateful for that. But if we're going to say that addiction's a disease, and if we're going to say that addiction's a chronic disease, and if we're going to believe it, and if we're going to regard it as such, then that means we also have to have that same respect and that same orientation towards people who are in the heart of their active addiction, people who are doing some ugly, ugly things we don't like. And we have to see those things as symptoms of a disease in order to really make a difference.
Along those lines, I agree. And I also think we need to remember that the people that are affected, there are people hurting out there. We heard this morning. And so I think that balance between kind of pain and hope, I think the people that are in recovery, I agree, people say it's anonymous. People need to come forward and share their recovery stories. I don't think we can get away from the ugliness. I think we need to kind of embrace that. We need to embrace that. That's not going to go away. And if you are that family member and you see that, we need to kind of embrace that. It is part of the illness, and there's no escaping it.
And, he's a Tiger Woods fan. I can say something about Yoda from Star Wars. Yoda said, "Mind what you have learned, save you it can." We've learned a lot about this problem. We've seen a lot just from the results of tobacco, alcohol. We've got to remember what we've learned and use that, especially when we're looking at possibly legalizing a third drug. And we've got to always be supportive of those people, those families, those people who are in that ugly stage. And we've got to continue working, but the support has to come afterwards. The gentleman who said there's two spectrums. Prevention, yes. We've got to get the horse in front of the cart with prevention. But for those people who are in long-term recovery, they have to have our support as well.
I'm on the executive committee for feduprally.org. We are having a rally in Washington, D.C. next week. We are, again, 6th year in a row, asking for a federal response to this epidemic. I think the states are doing everything that they can. We need more help from the federal government, more money. We haven't gotten enough yet. And changes at the FDA to ensure an epidemic like this never happens again.
Well, before we wrap up, I just want to end by saying that we've given you some ideas, we've given you some paths forward, but we certainly haven't solved this problem at all. The data that I presented earlier and the stories you've heard remind us that this is a very serious issue. While we have some ways of addressing it, we haven't done a good job of implementing them widely. So I see my role as somebody who helps support research is to do two things. One is to develop new tools. We need new, better approaches to both prevent and treat drug addiction. But we also need to figure out how we take what we already know and get it implemented on a widespread, consistent basis, because we aren't doing a good job in that either. So we have two parallel sets of problems that I'm certainly spending all my efforts every day trying to address. Really, please join me in thanking the panelists and for a lively way to start the meeting.